Bismillahirrahmanirrahim. I'm Fawad Ali, Assistant Professor, Department of Pharmacy, Part University of Science and Technology. Welcome to the course Pharmacology and Therapeutics, where we discuss about the clinical pharmacology and toxicology. In clinical pharmacology and toxicology, we discuss the chelating agents. In today's lecture, we will discuss the following contents like chelating agents, dimercaprol, succinimab, EDTA, or ethylated calcium disodium, penicillinamine, or also known as dimethyl cysteine, defroxamine, deferas, deferricerox, lecture outcomes. After watching and listening, this student will know about the chelating agent role in the drug toxicity. First, starting from the dimercaprol. Dimercaprol is a chelating agent that is used to remove the heavy metal that is removed to that is used to remove the heavy metals such as the lead mercury from the blood. Dimercaprol is used to treat arsenic, gold, or mercury poisoning. It is also used together with another medicine called as editate disodium or EDTA to treat the lead poisoning. So chelation, basically chelation is a type of bonding of ions and molecules with the metal ions. So dimercaprol is basically a chelating agent. So chelating agent, it is a type of bonding of ions and molecule to the metal ions. It involves the formation or presence of two or more separate coordinate bonds between a ligands and a single central atom. These ligands are called chelants, chelator, chelating agents. They are usually organic compounds, but this is not necessary as in case of the zinc. It is used in the maintenance therapy to prevent the absorption of copper in people with Winchell disease. So they chelation is useful in have application like providing nutrient supplement, chelation therapy to remove the toxic compound from the body. So first we first chelating agents we have like dimercaprol. It's a chelating agent that is used to remove the heavy metals such as lead or mercury from the blood. So it is used to treat arsenic, gold, or mercury poisoning. It is used together with another medicine called editate disodium to treat the blood poisoning. This is dimercaprol structure: 2,3-dimercaptopropanol. So this is the dimercaprol structure. Dimercaprol is also known as ball. Dimercaprol is an oily, colorless liquid and was developed in Great Britain during the World War II as a therapeutic antidote against poisoning by the arsenic-containing warfare agents lewisite. It is thus became known as in British anti-lewisite or ball. So it is an oily, colorless liquid and was developed in Great Britain during the World War III as a therapeutic antidote agent against the poisoning by the arsenic-containing warfare agent leviside. So it is known as the British, and because they are against the agent used against the agent leviside, so anti-leviside. British, like in the developed in the Great Britain War, so the word Britain came from here, from the Great Britain, and anti-leviside. So this is known as B for British, A for anti, or L for leviside. Because aqueous solution of dimercaprol are unstable. They are unstable, so and oxidize readily. So it is dispensed. Therefore, it is dispensed in 10% solution in the peanut oils and must be administered by the intramuscular injection, which is often painful. Because aqueous solution of the dimercaprol are unstable and oxidize readily, it is dispensed in 10% solution in peanut oil and must be administered by intramuscular injection. Dimercaprol is FDA approved as a single agent treatment of acute poisoning by arsenic and inorganic mercury, and for the treatment of severe lead poisoning when used in conjunction with the ADTA calcium disodium. It is FDA approved drug as a single agent treatment of acute poisoning by the arsenic or inorganic mercury, and for the treatment of severe lead poisoning when used in conjunction with ADTA. Although studies of its metabolism in humans are limited, they have limited study, like the use and the metabolism in the humans are limited. Intramuscularly administered dimercaprol appear to be readily absorbed, metabolized, and excreted by the kidney within 4 to 8 hours. When used in therapeutic doses, dimercaprol is associated with a high incidence of adverse effects. When used in therapeutic doses, dimercaprol is associated with a high incidence of adverse effects. For example, including hypertension, like this is a hypertension, adverse effects at therapeutic doses, tachycardia, nausea, vomiting, lacrimation, salivation, fever, particularly in children, and pain at the injection site. It has also been associated with thrombocytopenia, increased prothrombin time. Factor that may limit the intramuscular injection because of the risk of hematoma formation at the injection site. There are factors that may limit the intramuscular injection because of the risk of hematoma formation at the injection site. Second chelating agent is succimer, also known as dimercaptogenic acid (DMSA). Succimer is a water-soluble analog of dimercaprol. Is a water-soluble. Dimercaprol is an what they have a water insoluble. So succimer is basically a water-soluble analog of dimercaprol, used to prevent and reverse the metal-induced inhibition of sulfhydryl containing enzymes, and to protect against the acute lethal effect of arsenic. Like they are a one succimer is a water soluble analog of dimercaprol. They used to induce the sulfhydryl group containing enzyme used to protect the acute lethal effect of the arsenic. In humans, treatment with succimer is treated with an increase in urinary lead excretion. In humans, treatment with succimer is treated with an increase in urinary lead excretion and a decrease in lead concentration. It may also decreases the mercury content of the kidney, a key target organ of inorganic mercury salt. In humans, Visaximar is treated with increased lead excretion and a decrease in blood lead concentration. Obviously, it is excreted in urine, so the level of the lead in the blood is decreases. It also decreases the decreases the mercury content of the kidney, a key target organ of inorganic mercury salt. It is absorbed rapidly but somewhat variably after oral administration. It is absorbed rapidly, but there is variation after the oral administration. Peak plasma level of succimer actor at approximately 3 hours. So peak blood level of the succimer is about within 3 hours. The drug bind in vivo to the amino acid cysteine to form 1,2 and 1,2 1,1 and 1,2 mixed disulfide, possibly in the kidney. It may be these complexes that are active chelating moieties. So they bind in vivo to the amino acid cysteine to form the 1,1 or 1,2 mixed disulfides, possibly in the kidneys, and it may be these complexes that are active chelating moieties. The elimination half-life of transformed succimer is approximately 2 to 4 hours. So the typical the typical dose of the succimer is 10 milligram. It's 10 milligram per kg orally 3 times a day. Oral administration of succimer is comparable to the parenteral ADA in reducing the blood lead concentration. The typical dosage is 10 milligram per kg orally 3 times a day. Oral administration of succimer is comparable to the parenteral ADA in reducing the blood lead concentration. 3 times a day, oral administration of succimer is comparable to the parenteral ADA in reducing the blood lead concentration. Based on its protective effect on against arsenic in animals and its ability to mobilize mercury from the kidney. Based upon its protective against the arsenic in animals and its ability to mobilize the mercury from the kidney, they are protected against in the animals and ability to mobilize the mercury from the kidney. Succimer has been used in the treatment of arsenic and mercury poisoning. It is a negligible impact on the body stores of calcium, iron, and magnesium. No effect or negligible effect on the calcium and iron and magnesium ions. GIT disturbances including nausea, anorexia, vomiting, diarrhea are the most common side effect occurring in less than 10% of the patient. Rashes sometimes requiring discontinuation of the medicine has been reported in less than 5% patient. EDTA, editate calcium disodium methylene diamine tetraacetic acid, EDTA. EDTA या ethylene diamine tetraacetic acid is an efficient chelator of many divalent and trivalent metals in vitro. To prevent the potentially life-threatening depletion of the calcium, the drug should be administered only as the calcium disodium salt. Should be administered only as the calcium disodium salt. ADT8 penetrates the cell membrane relatively poorly and therefore chelate extracellular metanines much more than effective, much more effectively than intracellular. It penetrates the cell wall relatively poorly and therefore chelate extracellular metalines much more effectively than the intracellular. So they may therefore the chelate form extracellular with the metanine much more effective than the intracellular. The highly polar ionic character of the EDT limits its oral absorption. Moreover, oral administration may be increased lead absorption from the gut. Consequently, ADDA should be administered by intravenous infusion. ADTA, adidated calcium disodium is indicated chiefly for the chelation of the lead, but it may also have useful in poisoning by the zinc, manganese, and certain heavy radionuclide. So most effective in the zinc, lead, and manganese. Because of the drug and mobilized metal are excreted via the urine, the drug is relatively contraindicated in anuric patients. While the urine, the metals are excreted via the drug is relatively contraindicated in uric patient. In such instances, the use of low doses of PDATA in combination with the hemodialysis or hemofiltration has been described. Nephrotoxicity from the ADDA has been reported. Adverse effects have nephrotoxicity, but in most cases can be prevented by maintenance of adequate urine flow. This can be prevented by maintenance of adequate urine flow, avoidance of excessive doses, limitation of the treatment course to 5 or fewer consecutive days. So nephrotoxicity from the UDTA has been reported, but it can be prevented either by maintenance of adequate urine flow or by avoiding the giving excessive doses, limitation of the treatment, limitation of the treatment like course to 5 for fewer consecutive days. Penicillamine. Penicillamine is a white crystalline water-soluble derivatives of penicillins. It's a white derivatives of penicillin. D-penicillamine is less toxic than L. They are less toxic and consequently is preferred in therapeutic form. Penicillamine is readily absorbed from the gut and is resistant to the metabolic degradation. They are absorbed from the gut and resist to the metabolic degradation. Indication: penicillamine is used chiefly for the treatment of poisoning with the copper poisoning, or to prevent the copper accumulation, especially in the Wilson's disease, causing hepatolenticular degeneration. Its ability to increase urinary excretion of lead and mercury had occasioned its use in outpatient treatment for the intoxication with these metals. Ability to increase urinary excretion of lead and mercury has occasioned it used its outpatient treatment for intoxication with these metals. But Succimer, with its stronger metal mobilizing capacity and lower adverse effect profile, has generally replaced penicillin for these purposes. Adverse effect has been seen in up to one-third of patients receiving penicillins. So rare adverse effect. Hypersensitivity reactions include rashes, pruritus, drug fever, and drug should be treated with extreme caution if at all in patients with a history of penicillin allergy, like they have penicillin allergy causing, like for example, having chances of anaphylactic shock. So in that case, the drug should be used with an extreme caution in the patient with a history of penicillin allergy. Efroxamine. Defroxamine is isolated from the streptomycin pelosus. It bind iron avidly but essential trace matter poorly. They have a good binding with iron but bind essential trace matter poorly. Furthermore, though competing for loosely bound iron or iron carrying proteins, bound iron binding protein like hemosiderin and ferritin, it fails to compete for biological chelated iron, as in microsomals and mitochondrial cytochromes and hemoproteins. Defroxamine plus hemodialysis may be useful in the treatment of aluminum toxicity and renal failure. Defroxamine is poorly absorbed when administered orally. A poor oral absorption and may increase absorption when given by this route and may increase the iron absorption when given by this route. It should therefore be administered intramuscularly or intravenously. The iron chelator complex is excreted in the urine, often turning the urine as an orange-red color. Rapid intravenous infusion may result in hypotension, adverse idiosyncratic responses such as flushing, abdominal discomfort, rashes has been observed. Pulmonary complications, for example, acute respiratory distress syndrome, have been reported in some patients undergoing defoxamine infusion lasting than 24 hours. So, there are pulmonary complication, acute respiratory distress syndrome. If the patient is some patient is using defoxamine infusion lasting more longer than 24 hours. Def, defer, deference, deference rocks. Deference is a trident chelator with a high affinity for the iron and low affinity for other metals. For example, zinc and copper. It is orally active and well absorbed. In the circulation, it binds to the iron and complex is excreted in the bile. Thank you so much.